And so my question is, with this diagnosis, so how do you treat and manage this acute and chronic pain?
Right.
Here we go.
The first thing I want to say is that non-specific low back pain is not a diagnosis. It's a symptom. It's a description. It's a label you give a person before you know anything. If that is your end point, then you are confessing you know nothing.
Agree.
So now you go on to all the randomized controlled trials that have been done on a bunch of people with a symptom about which nobody knows anything. So is it surprising that if you take 100, 200, 300, 500, 1,000 people with non-specific low back pain, and you compare exercise with medication, manipulation with strengthening exercises, surgery with no surgery, what are the results going to be? The answer is nothing is better than anything else. And we have 25, 30, 50 years, nearly 50 years, 40 years anyway, of bitter experience of the fact that non-specific low back pain gets better or doesn't get better, irrespective of what you do, on average. Why is that? Is that because no treatment works better than doing nothing? No.
I don't think so.
That's the first thing. The second thing is that does back pain actually have a good prognosis? Well, originally in 1966, a paper was published by Delane et al., where they compared, this is out of the UK, the people having back pain, and they observed what happened. And they found that something like 80 or 90% of people got better, right? And that ever since then, they've said that back pain is a good prognosis. What is not well known is that that was taken from data coming from the doctors, general practitioners, and they assumed that a person who didn't come back to them as having gotten better.
Mm-hmm.
So that means that 80 or 90% of people don't go back to their doctor when they don't get better. Now, what we now, well, they should say, I'm sorry, I haven't actually said that quite correctly, but anyway, it doesn't matter. What it means is that's rubbish science. Now, back then, it was the only science.
Yeah.
Right? And I was still a teenager back then. So bottom line here is that when you have a group of people who will not go back to the doctor because the doctor didn't offer them anything, that is not a patient getting better.
Exactly.
Okay? So the next thing is that, all right, what is the prognosis? Well, we know that something like 30 or 40% of people experiencing their first episode of back pain still have significant symptoms at 12 months. Now, is that a good prognosis?
I don't think so.
I don't think so. We also know that it's a highly recurrent disease, that it may get better, but it comes back, right?
Yeah.
Like the common cold, right? Now, have we got a cure for the common cold? No. But we do know how to treat it symptomatically. Do we beat ourselves to death because we can't cure the common cold? No. We haven't got a cure for it yet. Have we got a cure for back pain? No. Why are we beating ourselves to death about that? At least we know the common cold is caused by at least one class of viruses. That's simple compared to back pain, because back pain can be caused by the disc, facet joint, the sacroiliac joint, a whole bunch of things. There's something like 100 different conditions that can give you the symptom of back pain. I think about 95% or even more is caused by about 11 different conditions, okay? But there are many different possibilities, all right? So that's fine. And now if you take those, say 11 conditions, which is 95% of the problems, and then and each one of them should have a different treatment. Should have, because you wouldn't treat that the same way as you treat that. You wouldn't treat that the same way as you treat that. So they should have different treatments. And then you put them all together and you compare exercise, which is a non-specific treatment, right, to a non-specific group of people, you're going to get garbage. Garbage in, garbage out. So if you're planning an RCT right now, compare on non-specific low back pain, save your money, do something else. We know what the answer is. The answer is it's going to be no better than doing nothing. Or if it is better, it's marginally better. All right, this is not new science. Moritz von Tilde did his PhD on this. He wrote a book 2001. This is now 20 years ago. And the conclusion was, from all the RCTs that have been done, the evidence strongly suggests that the differences between treatments are small, if there is any. Now, that hasn't changed in 20 years, right? So why are we doing more RCTs? To find out the same damned answer. So what is left? Do we know how to treat subsets of back pain? Well, the only subsets that the researchers seem to be interested in are the ones, well, if we treat depression or fear avoidance, or we do this, all the psychosocial predictors. And you know what? That doesn't treat the pain. It treats the condition or the behavior. It doesn't treat the pain. Cognitive behavioral therapy and cognitive functional therapy, which is the latest flavor of that by O'Sullivan, all right, shows we know that you can improve people's disability or decrease their disability, but not the pain. So why do people come to see me? Well, I asked them that. I actually asked them that question. After I finished my clinical history, the first thing I asked my patient is, what do you want from me? What, I mean, I know what the person who referred you to me wants because they wrote me a letter, but I want to know what you want from me. What would help you? And 90% of my patients say, well, I'd like the pain to go away. They don't say I'd like to be just less disabled or less anxious or depressed. They don't say that. Now, they may also say that, but almost all of them say, I want the pain to get less. I want to know why I'm hurting. I want to know what I can do about the hurting. Okay? And that's what I treat. The pain, not the disability. I obviously have to treat the disability because we know that getting rid of the pain doesn't get the patient back to work. We know that. So to me, as a clinician, I have to deal with all of that. But I begin with the patient. I don't treat populations. I treat individual people.